We must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show. Hello, everybody, and welcome to another episode of the Healthcare Education Transformation Podcast. My name is Brandon Pullen, and we actually welcome an international guest from across the pond. And today we have the esteemed pleasure of welcoming Bronnie Thompson, who was actually initially trained as an occupational therapist with psychology background and a PhD in health sciences. And she teaches postgrad studies in pain management to an interprofessional group of students and clinicians in which they cover the International Association for the Study of Pain curriculum, which includes 3 distance taught programs. Now, first and foremost, I'd also like to give a shout out and thanks to our friend Sandy Hilton of Entropy Physiotherapy and Wellness in Chicago for recommending Bronnie for this episode. Now, Bronnie, thanks so much for taking the time out of your busy schedule and for coordinating across different time zones, because I know between the both of us, it's not always easy to do that.
You did the calculations, not me.
I know. Well, it's just like, is this right? Is this right? Like, we've learned enough in the past from messing up. I'll put it that way. Yeah. But, I know there's more to your story than what I had just mentioned before there. So, for our audience, perhaps, who has not heard of you quite so much, do you think you could share your background and your journey to what really led you to pursue focusing on pain management and how you really ended up where you are today with all the teaching that you're doing?
Very good question. So, yes, I started as an occupational therapist, and throughout my journey working in hospitals and doing, traditional rehabilitation, pre-discharge planning, I got interested in vocational rehabilitation and looking at how do people go back to work. It's an OT thing, I guess. And I found that most of the people that I worked with had chronic pain as their main problem. And so I started to investigate chronic pain. What can we do better? What can we do in a different way? And at that time in New Zealand, there were no services or few services that were going into the workplace. So that's how I got excited about pain and trying to transform what we do. And then I got fascinated and started to do my master's in psychology because it gave me a whole lot more skills to use, and then PhD. And then I got an opportunity to start teaching in our postgraduate program when one of my colleagues left, and he was covering the psychosocial aspects of pain, and that's my passion. So looking at, we have a biopsychosocial model or a socio-psychology biological model, I think that's how you say it, if you flip it upside down, because most of us don't do much of the social. We'll get on to that. So I got the opportunity to start teaching, and I've been doing it ever since. So that's 14, 15 years now.
Well, Bronnie, do you think you could break down the specifics of what each of these international distance programs entails, from how it's structured, the cost, and the duration?
Yeah, so we have 3 broad strands. One is musculoskeletal medicine, and that's for doctors. It's a medical practitioners program that has certificate, diploma and masters, and that is really focused on improving diagnostic skills, learning much more about the tissues. So most of the recruits, people that start on that program are general practitioners, so family doctors who want to upskill, because at least in New Zealand, and I think probably elsewhere in the world, most of their workload, probably 70% of a general practitioner's workload are musculoskeletal problems. And so that program has 2 on-campus courses for, one is on diagnostics, so examination techniques, imaging, that kind of thing, where they learn on campus. And the second course that they do on campus is their procedures, so techniques with injections and dry needling and things like that. And then there are about 10 courses. We call them papers, but that's a course. And you can choose a range of courses to suit your needs. But there are 2 compulsory ones, and they are Introduction to Pain and Introduction to Pain Management. And so those form the core of all of our programs. Most people, or everybody, needs to do those 2 to be able to carry on to the next part. So the medical one has the on-campus component, primarily doctors, and the only time that the doctors are there are on those 2 on-campus courses. The rest of the time it's an interprofessional bunch. So then the second one is the musculoskeletal management, and that's really for people who want to look at the tissues more, want to understand more about pathology, diagnosis, and probably a slightly more medical orientation towards management without the hands-on component. Again, it involves the 2 Introduction to Pain and Introduction to Pain Management programs, and there are about 10 papers courses that people can take, and you can pick and choose. So if you do a certificate, you do 4, if you do a diploma, you do 6, and if you do a master's, that's a much longer program, and you do either a coursework, which leads you through a dissertation, or a research-oriented master's, which takes you down the road of a research thesis. And then the last one, which is the newest of our suite, is the postgraduate pain and pain management programs. So again, the 2 core papers, and then a number of other papers to do with neurobiology and biomedical management and psychosocial and cultural aspects of pain. And again, certificate, diploma and master's program. The cool thing is that all of these are open to anybody with health professional background, tertiary level training, and we train together. So there's no, only the doctors learn this part. Everybody learns the biomedical approaches, so pharmacology, imaging, all of that side, and everybody learns the psychosocial, the exercise, the whole range. And that means we have a great opportunity to learn from each other, which I think is fabulous.
I really like that, actually, like just listening to how this is so different from what I've seen or experienced over here, and that I like how it's so interprofessional, like you said, like there's a lot of blending with that. And I really like how everyone, no matter what, has to take those initial 2 pain classes to really kind of get everyone on the same page regards to pain, which I think is fantastic. I really, really love that idea. Is that something that's just that program has decided to do, or is that something that's like required from universities all around the area, or?
No, that was a deliberate decision by the founder of that course, Dr. Barry Tate, who incidentally was one of the founders of the International Association for the Study of Pain back in 1974. So he was a rheumatologist, and our program started in 1986, around that time, and he deliberately said, we want to have a biopsychosocial approach. And so when he started to do the pain papers, he said, we have to have it as a biopsychosocial model. So that's what we do. So it's not an obligation, but if we are to be endorsed by IASP, then we need to follow their curricula. And they have 9 different curricula. Our one is the interprofessional model.
Well, very nice. I want to go back one thing and just kind of break down for maybe someone who's maybe even listening perhaps in New Zealand, or even just people across the States who just maybe kind of want to just maybe compare, contrast cost for programs. How much does it on average cost for these programs, just from a tuition standpoint?
There are different fees for different for people who are resident in New Zealand and New Zealand citizens, and for those who are not resident and are not New Zealanders. Our government sets the fee structure, so we don't have much option there. And what that means is that students will need to know where, whether they're New Zealand students or not, or eligible for those. So each program, each paper, so each course costs overall, if you complete a master's, it'll be about $10,000, $11,000. So that's quite a lot of money. And break down each paper is about $1,800, I think. So it's not a small amount of money. But what you get are some conveniences. For example, you can use this platform. We use distance teaching for all of our papers. So that means people can be located anywhere in the world, as long as they have an internet connection and they have a microphone and a webcam, away you go. So you can be sitting at home, sipping on your glass of wine while you listen to somebody talking about their whatever the lecture is for the day. Add to that we record all of our lectures, and so they are held on Blackboard, which is our student learning management system. So even if you can't attend, for example, we have students from Hong Kong, and it's middle of the afternoon. We teach in the evening. So it's middle of the afternoon for them, so they can't actually get there because they're working. So they can listen to that recording. All the readings, so all the references are online, and you access them through our library. All of the discussion is on Blackboard. Submit your assignments online, and from next year our 2 core papers will have an online exam instead of having to sit and write. You have a 2-day open book online exam, which is kind of cool.
Yeah, Bronnie, I really like the structure that you're kind of explaining there. It's a little bit different, take on things as far as the U.S., but, seeing how continuing education is regulated here, I'd be curious to hear, kind of how it works as far as the process that it entails for getting these programs up and running. And, when it comes to legal matters or continuing CEU credits or stuff like that, how does that exactly work over there?
Good question, and it depends on the profession. So occupational therapy doesn't require hours. We have a needs-based, so we do an assessment of our own learning needs. We say how we're going to do it, any way as possible, and then we write a reflection on how this might change practice. So that's occupational therapy. But physical therapy or physiotherapy and medicine both have the number of hours of ongoing learning. And each of those registry boards have their own way of validating that what you're doing counts towards those hours. So for physiotherapy, there's a straightforward process. We assume that it takes about 10 hours a week to do a course for a semester, and that counts as, you'll see, continuing education. General practitioners have a different process, and we're just going through the process of reaccrediting with our GP colleagues. If you want to become a musculoskeletal physician, so a specialist in New Zealand, then this is part of your learning, and so it contributes to the fellowship process that you follow. So each one's slightly different. And so what we've decided to do is to follow the IASP curriculum, partly because it's the authoritative group or organisation that can say, these are actually evidence-based, this is going to cover the material you need to cover. And it also keeps us honest and not sort of diving off onto tangents or things that we think might be interesting but might not actually be that useful to our students. For setting up a program, degree courses in New Zealand are quite regulated. So universities and the technical institutes or polytechs can issue up to bachelor's and master's. Only the universities can offer PhD. So when we start to develop a new program, our university, like every university in the world, says, is it going to be cost effective? Are we going to be able to sustain this? So we were able to do that, and we've been growing our student numbers in the last probably 5 years to where we have a very healthy number of students for each group. Doesn't mean that you don't get a chance to talk, about 30 in the largest group for class. Otherwise, they're smaller groups of 10 to 15 people, so you get a good chance to talk to people. So we have to present our curriculum, develop the way that we teach and the assessment modules, look at the learning objectives, and how can we create a way of conveying information or helping students discover information, and then put that to our academic boards, and it goes up through a chain of approval process.
Interesting, as I always love hearing what the process is like from different countries, as we can learn so much from each other. Now, Bronnie, realizing that the programs you had mentioned earlier are for clinicians who have already graduated and became licensed, but I'd be curious to know how the entry-level curriculum accreditation and licensing process works in New Zealand, just to understand how it works over there.
So most people would get a physiotherapy degree, for example, with a bachelor's, and they might do an honours. And then they, at the end of that, sit their national exams. And so those are the organisations that are managed all of that process. The university, if we're doing an undergrad program, our program would have to be vetted by those boards to say, yes, you're covering off everything that you need. But for the master's programs, this is for practitioners who want a specific amount of training in a different topic. And it is an academic course as well as being clinically focused. And so the main process is that the QAP, which is the Combined Universities Assessment something, I can't remember what the P stands for, that is the overarching body that regulates the quality and the standards and the requirements for issuing a university qualification like a master's. So we had to meet those requirements. And then so we did that before we got our IASP accreditation, and we decided to proceed with the IASP accreditation because it means we're meeting the standard. IASP is the largest international group of pain professionals in the world, and that's what we want to have, is to be sure that we're following where they're going.
I know before you had mentioned that a couple big pros of these programs specifically include a lot of interprofessional education and opportunities, but also following, like you said, that IS curriculum and having everyone go through those first two courses that really give a solid foundation and exposure to pain on those levels. So I'm going to ask kind of like another question here. So what, other than those things, what else specifically makes these programs stand out compared to other interprofessional programs across the world?
We are, for Australasian people, we have a New Zealand, Australia focus, primarily New Zealand, so social context, some things that are unique to New Zealand. For example, we have the Treaty of Waitangi, and that means that when we're looking at cultural capabilities, so how people from different ethnic groups express pain or manage pain, we have a particular requirement and obligation to meet the Treaty of Waitangi, which means that we must include how do we respond to the needs of Māori. That's unique. You don't have that. Māori don't live anywhere except the Cook Islands in New Zealand. And I think that is a real strength for us, because if you can think about pain as perhaps being something we can't qualitatively share. You don't know what my pain is like. So we're always looking at the person as another. They're not me, they're an other. And with pain, we have, with people who have different ethnicities, we really have to listen carefully so that we don't assume that we're interpreting something that we would do, or that what they're doing is something that we would do. They may be doing it for different reasons. So, for example, Māori have a particular model of health, which is Te Whare Tapawha, which involves 4 strands: the biological, the psychological, the social, and the spiritual. And the spiritual, or wairua, is one of the most important threads for Māori. So we weave that in to particularly my paper on psychosocial and cultural aspects of pain. So that's unique. You won't get that anywhere else. The other thing, this is the only pain program in New Zealand. There is one in Sydney, University of Sydney, one in Edinburgh, one in Cardiff, and just a sprinkling elsewhere in the world who cover this curriculum. So that means that, you need to choose the one that's going to be most like your practice or has the most flexible learning options. And I think our options are pretty flexible, and I try to keep it real. Let's see what you can do with this learning and apply it in your place. So my assessments are based on, what do you really need to know? How can you apply it? Now show me.
Yeah, that's awesome, Bronnie. And I when it comes down to talking about application, have you guys done any research at all on outcomes of either clinicians that have gone through the program or patient outcomes of patients that have been treated by the clinicians that have gone through the program?
Well, no, and one of the reasons for that is the youth of our pain suite. Musculoskeletal is different, so I'm going to talk primarily about the pain suite. So our degree started about 5 or 6 years ago, so it's new. And so we're waiting till we get the numbers up to a reasonable number before we have a look at how things are panning out. What we do know is that people who complete our program have gone on to lecture, so gone on to a career in teaching. They are taking leadership roles, so they might take a leadership of a pain management group or program. They're helping to develop policy, so amongst our public health system and in ACC, our national accident insurer. So we know that the people who complete our program are progressing their careers. As far as money goes, pay in New Zealand is kind of tied, and particularly for allied health, we don't have such a great career progression. But our students, by and large, are senior. They have discovered that they have this passion for learning about pain, and they develop these specialist skills. So they can go on to become a specialist clinician in pain within their discipline. And I think that is also a recognition of your extra effort and skill in learning.
Oh, absolutely. And I mean, because it sounds like quite a process to go through that. And especially with what you had said, it sounds like a great process. But, you talked before about a lot of the pros, and it seems like there's a lot of them regarding this, which is really why this is so exciting. But how do these programs look to expand or change to meet the future needs of patients and healthcare providers?
Good question. So we were one of the first programs to begin to do distance teaching. And way back in the day, we used to hang off the end of a telephone. We didn't see the people, we had no video. So I would be teaching for an hour with, on a phone, which was hard work, but we did it. And then we started to put things online as the internet matured, started with Blackboard and putting video links and access to a lot of different resources that are found on the web. And then we moved to Zoom, to our video conferencing, which has been really good. So in terms of teaching delivery, that is an innovation, an ongoing innovation. We're moving to the exams where we're having an open book online exam, which is kind of reflecting the way that grown-ups learn and respond. So if you meet somebody, a patient who has a particular need, you don't go back to the book, or just sit there and kind of get it out of your brain. You would go to the internet, you would probably scour a database, you'd have a look at guidelines, and you would bring that information back, do an assessment, and then formulate your treatment. And so that's essentially the way that the exams will be. Here is a patient, a clinical scenario, recording of somebody, and your job will be from whatever perspective you work from, nurse, occupational therapists, psychologists, physiotherapists, podiatrists. Who else have we got? Osteopaths, chiropractors, massage therapists. Keeps the learning fresh. Every time we do teach us a course, we review the modules, we have a look at the latest evidence, and we have a look at modifying or changing what we need to teach.
Yeah, that sounds like a great plan moving forward, Bronnie. What would you say are some of the barriers that you've come across, either you or the students, in these programs?
Probably the biggest barrier is in parts of New Zealand do not have broadband. Some of the remote areas of New Zealand haven't got broadband, and so they have to use satellite phone or dial-up, and that's a problem. I can see some interesting expressions here. Yeah, so although those that do have fibre will have very fast fibre, so that's quite good. I think cost is probably a problem for international students in particular. This is not cheap, but I don't think any courses, postgraduate, university level courses are cheap. And I would think of it as scratching an itch. If you have a passion for learning and understanding pain, then you need to learn how to read the literature, what is important to look at, what is not important to look at. And I think this program does give that. I suppose the other issue would be it does take time. So each paper, as I say, about 10 hours a week. So most people will only do one paper a semester, one course a semester. And that means that it will take you a wee while to get through all of your learning. Most of our clinicians are working at the same time as studying. If you're doing it full-time, not a problem. But if you are a clinician and you're fitting this into all of your other activities and life, children, fun, holidays, all of that sort of thing, then putting it together can be one of those juggling things that I think any postgrad student who happens to be a mature student ends up having to do. And we try to understand that. So when people have to ask for an extension, I am really happy for that as long as there are reasonable grounds for it. So I think those would be the two really big concerns, that it takes a lot of time and energy and it can be expensive.
No, I agree. I think that's definitely very similar over here in the US as well, because I've heard that numerous times on previous episodes. And, I want to kind of go off and kind of focus a little bit more on ISP a little bit more, just because I don't know how many of our audience has actually heard of it as much. So with you and your position being a teacher, what do you feel are the strengths and limitations of the International Association for the Study of Pain's interprofessional curriculum? Because I'm really curious to hear what are your thoughts on it.
I don't know of any limitations particularly. I think that the curriculum experts have worked together, so each discipline developed their own curriculum, and as I said, there's 9 of them or 8 of them, and then they put those general orientations into this interprofessional curriculum. So I think it honours biopsychosocial model. I think it honours the fact that we all have a common language. So when we're talking about pain, we are using the same understanding, the same frameworks. And that is, I think, quite unique, really. We don't have, there are so many different ways you could look at pain. We could look at just, biomechanical forces, or you could look at a cellular level. We're thinking a systems approach. We're thinking that there are biological elements, definitely. There are psychological aspects and social aspects, and how can we blend all of that? It's a challenge, and I guess we are not saying only psychologists can do this stuff and only physios can do that stuff. For us, the only thing that we restrict is the on-campus courses for the doctors, and that's under the musculoskeletal banner. So the strengths of that is that when you're working in a team and pain management is better delivered under a team, you know how to speak to the other professionals that you're working with. You have a common approach, a common understanding. And while you might not be expert in, say, as a physiotherapy in psychology, you know how to identify those risk factors. You can't identify them if you don't know about them. And then you can manage what you can manage in your own practice and refer appropriately, and then work together to support in your sessions the sorts of things that maybe the psychologist or the occupational therapist are doing in their sessions. So rather than being siloed, we talk about an interprofessional group. So just to divert, so single disciplines, I'm doing my thing, I'm just doing it. Multiple disciplines or multidisciplinary. Somebody I respect called it serial monotherapy. So all of you are doing your stuff all at once, but you might as well be not seeing each other. So OT does OT stuff, nursing does nursing stuff, physio does physio stuff. In the interprofessional model, we're blending. And so it's not uncommon for me as an occupational therapist to talk about medication timing and side effects with somebody. For the psychologist to say, hey, this is why you're doing these exercises. For the doctor to say, hey, you need to see the OT because it's time to have a look at some practical, everyday application of what you're learning. I think that means that you can then really solidify, and people don't have the chance to fall through the cracks because somebody didn't talk to the other person, or getting mixed messages, which is the other risk.
Yeah, I think those are all really good points, Bronnie. And I think, one of the reasons we started this podcast was to really break down the barriers between disciplines in the medical fields, because, we really do all need to be working together, and interprofessionalism is such a big aspect. But from that aspect of things, when you look at a bigger picture here, what do you think all healthcare providers need to know about pain management before they graduate?
Best thing is go onto the IASP website and have a look at the interprofessional and all of the discipline curricula. Those are for entry-level clinicians. But fundamentally, we should know neurobiology, some basics at least. We need to know the distinction between the biological sort of substrate that's producing or helping to produce this experience, and that pain is an experience. And it's an emergent experience that comes from the biological, the psychological, which a lot of that is biological, things like attention, emotion, understanding beliefs, those are all biological, and the social emergence. So we understand that pain is that complicated and that we don't really understand it, which is, I'm happy with that. We still haven't got to understand consciousness yet either, and I think when we solve consciousness, we'll probably solve pain. So we need to know that. We need to know the difference between acute pain that will likely resolve and persistent pain that is unlikely to resolve or may fluctuate over time. And we know that at the moment there are no 100% treatments that are 100% cures for common, simple low back pain. As a result, we know there are a lot of people living there with low back pain, and we need to have some kind of common understanding of how do we handle that. How do we tell people that, it's likely you'll have back pain again, so you can manage it. So I think that that distinction between acute pain, persistent pain, and then the difference between having pain and being disabled by it, which is my research interest. So you can have pain and be highly disabled, and you can have pain and not be. And I'm interested in the ones that are not, because we can learn from those people. So that, to me, is one way of trying to cross-fertilise and kind of understand strengths-based rehabilitation, which has not really been a thing in pain rehabilitation.
Yeah, I think you brought up so many important topics and so many different perspectives on that, because I think that's so important that any clinician, even frankly a newer clinician, hearing that, like especially the phrase, like the one I'll say that you said that really stuck out was, we're not certain about what all is going on and how it all works, but that's okay. We don't need to know every single little answer to help people. No. So I think that's a huge thing that you mentioned. I think that's going to help clarify a lot of stuff for some students.
Yeah, I think one of the other most important things is to know that communication skills are crucial People with persistent pain feel invalidated because people don't believe them. So to listen and to then walk through and guide somebody through their experience to help them make sense is really important. And that means knowing something about pain, but it also means knowing an awful lot about how to work with people rather than coming in as an expert, top down, coming alongside somebody and helping them make sense and decide what they want to do next with their pain, whether it's acute pain or persistent.
So, Bronnie, you kind of had mentioned earlier in the pre-show about another specific niche that you've kind of been working on yourself when it comes to education. Do you mind telling our listeners a little bit about that process and kind of what it entails?
Yeah, so I run a patient program for people who have persistent pain, and it's called Springboard, and it's based on acceptance and commitment therapy and helping people become more of themselves. It's a discussion format, so it's not about me teaching. Well, it is about me teaching. The group works together to solve problems, to say, how can I do more of who I do, the things that make me feel like myself. And that starts with what's pain? And so I ask the group, we have up to 8 in a group, what have you been told about pain? And what sense do you make of that? What's your theory? And we put that all up on a whiteboard. And we try to help get people's heads around the various things that they've been told to make sense of it. Because people don't always hear what we say. So for this group, it's a lot of whiteboard drawing with little arrows going all over the place to just cover the fact that pain is a biopsychosocial experience, and that there are so many different factors that lead somebody to do what they do or to experience what they experience. So that's a really great session. And then at the end of each of our sessions, there are 6 of them, they have a mission. So this is home-based learning, or we used to call it homework. But I don't know any adults who actually like the idea of doing homework, especially people who come onto pain management programs. We have a lot of manual workers or people who've done a lot of heavy physical work. They don't like pen and paper. And school was probably where you went to have your play lunch. So we talk about missions, things that you can choose to accept to do. And so each person sets themselves something that they can commit to over the coming week, and then they do it. And then at the beginning of every session, we debrief. How did it go? What got in the way? What were your issues? How can we work around that? What can we do to solve the problems? And then we'll do another kind of teaching session and so on. So the topics that we have, what's pain? It's the first one. The second one's about the changes to activity levels. So I don't teach about pacing or, booming and busting. From the group, we learn that people do a whole lot on one day and not very much on the next day, and we explore why. And we find people who just keep going, and then crash. The overdoers. And then we have people who found that their activity levels are slowly reducing. And then we have those that's just dropped and now they're starting to build up. We just talk about what's it like and normalise the fact that the way that we do daily life differs. Even you and I will probably do a boom and a bust around, for you guys, Thanksgiving. You run around, as my partner will say, like a blue-assed fly to do Thanksgiving, and then you crash.
Yep.
Induced.
Yep.
And that is normal. And so when we say to the people that we work with, what I'm trying to convey is that the way that you do these things differs on context. So there's no one right way to manage pain, but there's degrees of workability. Workability in the short term and workability in the long term. So helping people puzzle through the best structure, best approach for them in that situation at that time. So it's a lot more fluid and flexible than traditional, you will learn to do your pacing kind of thing, or you will learn to reactivate. So that's quite fun. Then we do one on what to do with these thoughts and beliefs that we have, and how do we handle the sticky mind. And that's where I really introduce It's Kevin Polk's The Matrix, which is a very simple ACT model where we look at away moves and toward moves. And we look at inside stuff and outside stuff. Away moves are things that take you away from the life and the values that are important to you. And towards moves are things that take you closer. And then we've got inside stuff, which is usually thoughts and emotions and feelings and sticky stuff that kind of gets in the way of doing things. And we've got external stuff, which is the actions that other people can see. And how can we find some wiggle room to go from the things that show up when you try to do something and your mind gets to jump on you and say, oh, we shouldn't do that. How can you find some wiggle room? How can you do little shifts that help you do more of what makes you feel like you or what is important in your life? So that's really incorporating the idea of mindfulness, of choice making, of actions that are aligned with what's important to you. Don't get too technical. I've only got one session, but that seems to be picked up quite well with the participants. They get the idea of thinking of pain as clean pain. This is pain that's just the sensation. And then the thoughts about pain, which is dirty pain. I hate my pain. It's horrible. I can't do things because I'll hurt or I'll harm myself. And they seem to get that distinction quite nicely. So I find it a nice flexible way of introducing some thought stuff and some psychological stuff without having to do thought records in good old CBT. And then what else have we got? One on sleep, because most of the participants have trouble with sleep. So we just do some sleep hygiene, some analysis of what's going wrong. They swap notes with each other about what works for them. And I talk about an ACT-based approach and even introduce some sleep restriction for the people that need it. And we know the relationship between rotten sleep and increased pain. And so this is giving some understanding around normal sleep architecture and the sort of things that influence your sleep. And people usually go away with a mission to change something, to turn the device off at night, not to read on Facebook or something while you're in bed, not to eat in the middle of the night, those sorts of things. And then the last two, the second to last one's who's on your team, and that's all about the people that you encounter when you start to have a pain problem. So that might be your case manager, your GP, it might be the psychologist, it could be your employer, the HR department. We just put all those people out there, including family. And then we talk about what would you really like to say to these guys, which is interesting because there's a lot of misunderstanding. And so we talk a little bit about assertive communication, the difference between clobbering somebody over the head with an aggressive response or pussyfooting around and not being very straight with people, not being quite passive, and talk about how you can convey a straight up message. So people, again, have a little bit of a mission at the end of that, and it's usually to connect with someone who's important in their life in a way that aligns with their values. And the last one is let's draw up your personal pain management plan and let's look at setback plan. Shit is going to happen, I'm afraid, and let's plan for it and let's manage it. Anticipate where the problems are likely to lie and develop some strategies around that. And they write a 2-page self-management plan that then they take away as they've already had a workbook, but this is an extra piece that they take away and use to be the guide for the rest of their lives, I hope, or to take to other professionals when they want to try stuff out.
Well, I really like that. I mean, there's so many avenues of this that I like. First and foremost, you're going to the public. You're going to the people that need it. B, it's a very collaborative, open environment. It's also kind of got a lot of big social support to it, which I would assume also significantly helps too. And I really like how you really specifically kind of target each of these individual areas to really help that individual have the maximum best understanding, perception, talk about things that are important and what's going on to give some perspective to other people. They're like, oh, that you're experiencing that, you've tried that works. Oh, I wouldn't have thought of that. And then also how to prepare for when stuff happens.
And it happens.
It does. No, it does. But I really like that initiative. How long have you been doing it for?
This will be the second year, and so I started it myself about 2 years, 2 years ago, and then there have been other clinicians in other parts of New Zealand who are picking that up and doing it as well, and so we will get some outcome measures integrated. We have a thing in New Zealand and Australia called EPOC, which is Electronic Persistent Pain Outcomes Measures, and that is an online suite of outcomes that all of our insurance clients complete, pre, post, follow-up. But because they're done at the beginning of an episode of care and then at the end, they don't tease out the contributions of various parts of that plan. So I have picked up another set of measures that fit with ACT and use that as my outcome measures. So we'll be starting to do that. And they use those during the session. So they get to track and understand, more willingness to do stuff, even if it's not pleasant, more flexibility in how I do things, less trying to control my pain and more, actually, I can just be with it, that kind of things. And values, of course. I can take my pain with me, because we know that if you try to control pain, particularly persistent pain, it just doesn't get controlled. You're controlling your life, really. So even though some of the participants are quite early on in their careers with pain, and there's a possibility we'll find a cure or something that will take pain away. So I'm not trying to say you now must accept your pain. I'm just saying, are you willing to do things that bother you a little bit, that might increase your pain a little bit, if it's important to you? Great example, chap is a motorcyclist, and he said he's got back pain, he's in the group at the moment, so when he goes for a ride on his motorbike, it hurts, but is it worth it? Yeah, you bet. So that's a good thing. If people can learn that it's okay to have fluctuations in pain, then the fear and the desire to control that experience drops, and the more willing people are to do things that matter to them. And in the end, that's really what we want for people, is a sense that they can do the important things in their lives, whether they have pain or not.
Oh, absolutely. No, I completely agree. And it's really been a very enlightening discussion, Bronnie, especially talking about the university classes and then also this initiative that you're doing, which I really admire you for that. I think that's absolutely fantastic. I think we need more of that in the States here as well. But we usually like to ask this one question to each of our episodes at the end, and this is kind of our big one here. So the question that we ask is, if you could change one aspect of healthcare education, which aspect would you change and how would you change it?
I would like to see more emphasis on communication. That would be my fundamental. Because if we can hear one another, whether we're professional to professional or professional to patient or professional to policymaker, professional to insurer, if we can communicate well, we have a much better chance of trying to find some solutions. So I would begin with that. How would I do that? I would love to see a lot more interprofessional training. And so, yes, we do that on our postgrad programs, but I'd love to see that much earlier, so on our undergraduate. In the university that I'm in, there are interprofessional courses for the first year of health sciences students. Everybody is trained on the same stuff. But then we've got to look, as people develop their professional identity, how can they still communicate? So that's my two things. Better communication skills, particularly learning that Socratic questioning or guided discovery, reflective listening, using motivational interviewing. Number one thing for people who are working in pain, across the board, doesn't matter who you're talking to. And number two, get it done early as an interprofessional approach.
I really like those recommendations. And to kind of do one follow-up of that, if there are any students perhaps, or any clinicians listening for that matter that are like, maybe that is something I want to pursue more of, and maybe I can't go back to like undergrad or my regular schooling, but what are some of the best resources that you have found that specifically kind of helps individuals progress in that avenue specifically? So
motivationalinterviewing.org is the best place to have resources. A lot of them are free. On motivational interviewing. So that's www.motivationalinterviewing.org. YouTube have got a lot of motivational interviewing podcasts, I suppose, videos. And also, if you're looking for ACT material, Kevin Polk has a wonderful lot of videos on YouTube, and also Russ Harris. Not all of them are specific to pain, but the one that is on pain by Kevin Polk is just wonderful. It works so well with people. So I would begin there.
I love it. And for all those that are listening, they're like, where can I find this? It is all posted in our podcast show notes, so please just take a look on over and you'll find all the resources. Well, Bronnie, thank you so much for the time and for the very enlightening discussions. I've certainly learned a lot about different educational roles and even just a lot of stuff in general about pain that I frankly didn't know quite as much beforehand. So thank you for that, first and foremost. Where can people find you online or on social media should they have a question, want to reach out, or just kind of want to follow you a little bit more?
So I'm on Facebook as Bronnie Lennox Thompson. Most welcome to either follow or friend. If you got a friend, talk to me, won't you? I've also got my blog, which is www.healthskills.co.nz, and there's 10 years worth of blogging there. So I've been doing it a long time, and there's a lot of material there, lots of links, lots of reviews of papers, lots of stuff on there. I'm on Twitter, but trying to spell my username is probably impossible, so let's not do that. So I'm also on LinkedIn. You're most welcome to contact me via LinkedIn as well.
Well, perfect. Well, again, Bronnie, thank you so much for the time and insight and for coming on the show today, because I think this is definitely a very valuable episode for our listeners to hear. So thank you again so much for coming on. It's always a pleasure.
Thank you. It's been a pleasure too.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available in our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.